पहले अल्ट्रासाउंड करके दिखाना है। प्लास्टिक ग्लव भी हो। एमिनोरिया कितनी है? 16 दिसंबर है ना, तो 7 वीक। इसको वाला ग्लव दो,
पन्नी वाला ग्लव
ऑन। हाँ हटा दो उसमें। अभी इसके नीचे रख सकते हो क्या? संभाल के रख दो। वो ट्रॉली कहीं हटवा दो। अब इनको ऐसे ऐसे तो गाउन पहना रखे हैं, ये मुड़ गए तो इसका गाउन ठीक करो। ये पीछे से सब अपनी स्लीव अंदर करो, किसी की भी नहीं दिखनी चाहिए, पूरा अंदर। अरे ना रिवर्स करके वो चीज दिखा दो ना जब तक। किसी और से करवा दो ना उधर जाके। यहाँ पे जो लड़का खड़ा किया था, ये सुनीता को हटवा लो, इसकी जगह लेखपाल ले लो, तुम हटो। हाँ पूरा मोड़ना पड़ेगा, ठीक है। So good morning. Today we are going to show a case which is a very early Cesarean Scar Ectopic Pregnancy. A 35-year-old female married for 2.5 years, and the last cesarean was done about 1 year back with a transverse cesarean scar. So today we will first start with doing the ultrasound in the theatre. Gloves. So this patient, I'm doing a transvaginal scan in the theater itself. So we see a small gestation sac. Her LMP was 16th of December. So that makes it almost 7 weeks of pregnancy. You can see a small yolk sac also there. But also this patient has received 2 doses of methotrexate on, yeah, as you see here, there's a average chorionic reaction. So she received 2 doses of methotrexate 3 days apart, and now the serum beta HCG, in spite of the methotrexate injection, has not come down. So we decided to take her up for a hysteroscopic removal of the Cesarean Scar Ectopic. Okay. So now we shut off the ultrasound. So now we'll go with the resectoscopic technique. For this, serial dilatation will be carried out. All aseptic precautions have been taken, and I need to just swab it up after the ultrasound. Close up. बड़े बड़े. A Foley's catheter has been placed inside, and now we will first start with the gradual dilatation. So like yesterday, we went live with a case of cesarean scar ectopic, but that was a much bigger sac and previous to C-section. So the advantage of diagnosing early is that we can still resort to only hysteroscopic removal. We need to give a injection, centostinon, methadone, prostadine. How can I see? लगा नहीं अभी कुछ भी लगा दो ना डिटर्जेंट लेना लेके जाएगा So we will give a like methadone, centostinon drip, and carboprost injection, and the dilatation will be done for a receptoscope. Hopefully everything is ready with the foot pedal, please. Are we showing this end? Acha, are we showing the vaginal end picture? Vaginal end picture दिखा रहे हो? But how will it go in? Fluid बाहर नहीं आएगा. So I'm using a double barrel resectoscope, 26 French, and I'm still using a monopolar. Many of you might ask, but since Safety is one thing. So bipolars are designed for that. तो थोड़ा सा रखे रहते हैं. And now the fluid. So yeah, the first we start the fluid, we make a thorough check that there are no bubbles.
Slow down. ऑन कर दो फ्लोट.
There are 4-5 people over there. One, too many people. Please remove some.
बबल आ गए.
Yeah, so we start and see that there are no bubbles. Okay. So once we are very clear that there are no bubbles, then only we start our entry. So a white balance has been done. So gradually I'm making my way in. So there's no need or never any need to rush or push. It should be a very gentle entry. First we reach now we reach the internal os, and that is the cavity. So it's very good logic to stop at this point, adjust the camera focus and see for the picture clarity, and then I make my way in. Pressure should be consistent. As the pressure falls, then you will not see the picture clearly. Yeah, remove this. I think we had gone past the ectopic. So now there's from the external os, we are moving in now through the internal os, and a gradual entry is made in. Light to puri karo. Increase the light. Yes. Can we have a little suction, please, so that these clots can move out?
सेक्शन ये उसमें लगा दो.
With a lesser pressure. Pressure थोड़ा बढ़ाओ so that this clot comes out. So now that's the normal cavity. Okay, this is the niche.
Nutan Jain, बंद है.
Oh, yes. Start. Hmm. You see the chorionic tissue over here only. Just now we see the bluish chorionic tissue over there. So I think now I'll need to use some electrosurgery. So now that's the bluish chorionic, the sac contents. Cautery, वो देखो, cautery strength. 100, 100 of cutting. So we keep a measured. इसका ये side up हो जाएगा patient का, because the right side is getting a little difficult to reach. So I'm asking the patient's right side to be, left side to be elevated a bit. So just inside the internal cervical walls, we see the gestation sac. So let's go in a little and check. Yeah, so only that is the portion of the ectopic, and we need to continuously keep doing it till we reach the basal layer of the endometrium. Very important to be careful not to resect any deeper. So I'll just wait for a moment to bring out the pieces. Yeah. Can we have the syntocinon a little faster? Lot of bleeding. Light bleeding. The uterus doesn't look to be hard enough. Prostadin. काफी है. Hold. Okay. Yeah. So now after removing the whatever the pieces we had dissected, we are just simply going in to do a check inside. So gradually, as we make our way, so now we see now still a lot of contents there. So first we will remove them and then we will go for the resection of the knee as we see. So here it is. The only thing comes to my mind is that yesterday we had shown Cesarean Scar Ectopic. Almost a week back there was another scar ectopic. So such a high incidence of Cesarean scars ectopic really needs introspection among the gynecological obstetrician fraternity that what is giving rise to such high incidence that within a week. And there's another one which we are right now trying to bring down. So what our plan here always is that whenever we see a scar ectopic, so the patient is not immediately taken up for laparoscopic or hysteroscopic surgery. We try to control the serum beta HCG levels and the vascularity by giving injection methotrexate. So they are given in the dosage of 1 milligram per kilogram body weight, and the patient is allowed for 3-4 days unless she is symptomatic, so that the value drops down. The active pregnancy, if at all it is there, stops growing, and then it is much easier to take them up for surgery. I have not still found any very small one which has responded completely to methotrexate injections. Most of them have needed surgical removal, which could have been either for the larger ones, it is, and with a bigger niche, it is always laparoscopic, so that we do a good closure also. So have you given any lessons? We usually, since I'm using a monopolar, the anesthetist is very vigilant, keeping a check on the inflow, outflow, looking at patient's vitals. So in histoscopic surgery, it's very important that it's a very sophisticated teamwork. The fluid management, the keeping a check on the inflow, outflow. So everything goes hand in hand for a safe surgery. थोड़ा सा टेबल की हाइट आ So I think I should once clear up everything and see once more. So with the true clear system, the benefit comes that we can keep removing the tissue and at the same time it gets cleared by the mechanical and we do not need to use or stop the procedure. But then the cutting away of the niche is far better with the stethoscope. So it was looking like to be a very small sac, but finally it has come out to be more sizable than what it looked like to be on ultrasound. It's an organ. No, we still a lot of tissue is there. So we usually do an ultrasound. But what I saw just now was that we still have a lot of tissue. So we will just do it. First do a histoscopic check and if we feel that we have completed, then we will do a check with the इसके अंदर I can see somebody's face है ना क्या ये ठीक करूँ monitor वो monitor yeah I'll focus it a little more mm-hmm. Just open it. No इसमें बीच में we can do the scan करें we see some so most of it is fluid inside the cavity but at the end we still see a lot of chorionic tissue okay so we will go back to the histoscope. So I have to just totally reverse and now here you can see the niche which I am dissecting away. So I think very small little tissue is left. So we will just do one more scan and follow up the patient. I'll just review the ovum process. So as we saw in the last picture that most of the chorionic tissue ectopic content has been removed. The scar niche has been tackled with the resectoscope and this patient will be followed up by 3 ultrasound after a week and then serum beta HCG level. So currently our serum beta HCG levels are 14,000. So we will watch them till keep on estimating them accordingly and if they show a slow fall, injection methotrexate can still be continued. Thank you. So we will put up the whole video in the evening after uh, some for you to view in the evening. Okay.